Deep pits and fissures are the source of some 80% of tooth cavities. This is mainly because food and bacterial plaque lodge in these tight crevices and are often inaccessible to toothbrush bristles. Plaque acids and enzymes at the base of these grooves cause the tooth enamel to dissolve, eventually leading to cavities. Over the years, many attempts to stop pit and fissure tooth decay have been made. Here are the most common, their strengths and weaknesses. Fissurotomy, or prophylactic odontotomy, involves funneling the grooves open with a cone-shaped dental burr. If done early enough in grooves that do not extend through the dentin layer, it may be possible to perform this procedure and nothing further. More commonly, however, the deepest pits and fissures do extend close to or into the dentin layer, and this procedure must be followed by placement of a filling of some type. The procedure must also be performed by a dentist, since it involves removal of tooth structure. The grooves can also be cleaned out less invasively with a microabrasion handpiece, which sprays a stream of abrasive particles deep into the pits and fissures to remove plaque bacteria and roughen the enamel surface. Since microabrasion doesn't completely eliminate the deep, narrow crevices, it is usually followed by placement of a dental sealant. If the preparation of the groove extends into the dentin layer of the tooth, a filling is placed instead. Following thorough plaque removal from the pits and fissures, the tooth is isolated from all mouth moisture and the grooves are etched with a mild acid solution. This produces a microscopically roughened surface into which the sealants will adhere. The sealant is then applied to the grooves as a viscous liquid, which hardens on its own or by exposure to a blue light. Once placed, the sealant prevents bulk plaque from being able to accumulate in the pits and fissures. But sealants do have some potential downsides. It is possible for microleakage to occur along the sealant, especially if moisture is present when the sealant is placed. If leakage does occur, it may be difficult to detect until a large cavity develops beneath the sealant. It's important to remember that sealed teeth are not completely resistant to tooth decay. It's a big mistake to relax nutrition and oral hygiene standards on the belief that sealants alone will prevent cavities. And remember to see a dentist regularly to have the sealants evaluated for signs of failure, part of any thorough oral exam. Left alone, a poorly contoured failing sealant like the one shown is at least as prone to decay as an unsealed tooth.
First, indicate the teeth that sealants would benefit. Clean the surface from debris, stain, and calculus. Isolate the tooth with options such as the suction, cotton rolls, or dry angles. Dry the area for 20 to 30 seconds. Apply acid etch within the grooves and fissures where the sealants are to be placed, based on the manufacturer's recommendations, which are from 15 to 30 seconds. Rinse for 30 to 60 seconds. Dry the area for 20 to 30 seconds. The tooth will have a chalky white appearance when fully dry. If not, or if contamination occurs, re-etch. Then re-isolate if necessary. Place the sealant material in the pits and fissures only. You may have to use a microbrush to remove any bubbles and to remove any excess material. Using patient and clinician UV eye protection, cure the sealant material as per the manufacturer's recommended amount of time, usually from 20 to 30 seconds. Gently check for voids and complete coverage with the Explorer while maintaining a dry field. If at any point you find an issue, you can add additional material without having to re-etch if the surface has not been contaminated. Remove the isolation with a small amount of water so it won't stick and pull the tissues. Evaluate the occlusion with the articulating paper. Overfilled areas may require adjustment with an instrument if using unfilled material, or a drill with use of a filled sealant material. Floss the contacts to ensure material has not flowed into the contact.
This video will demonstrate the tray application of topical fluoride on a patient. The use of fluoride provides the most effective method for dental caries prevention and control. Fluoride treatments are not limited to use on children. Many adults with a high caries rate or root exposure can also benefit from professional fluoride application. There are 3 basic topical effects of fluoride. Topical fluoride prevents tooth demineralization. It enhances remineralization of incipient lesions. Finally, topical fluoride maximizes resistance to dental caries by inhibiting bacterial activity. There are a variety of fluoride agents available for professional application: 2% neutral sodium fluoride, 1.23% acidulated phosphate fluoride, 5% sodium fluoride varnish, and 8% stannous fluoride. Acidulated phosphate fluoride is the most commonly used agent in clinical application. Professionally applied fluoride agents come in 4 delivery methods: gel, foam, varnish, and rinse. We will be demonstrating the use of the gel application in this video. The supplies needed for a professional tray application are 1 maxillary and 1 mandibular disposable fluoride tray, a 2x2 gauze square, a mouth mirror, saliva ejector, an air-water syringe tip, and a timer or wristwatch, and the appropriate fluoride agent that is based upon the patient's caries risk assessment. In preparation for the procedure, a rubber cup polish is not routinely necessary before fluoride application. A toothbrush is then recommended for biofilm removal. Review the patient's medical history for any contraindications, such as food and dye allergies. A detailed explanation of the rationale and procedure must be given to the patient. The patient will need to be instructed to avoid swallowing the fluoride during the procedure, and that the duration of treatment will be 4 minutes. Before starting the procedure, place a barrier over the fluoride bottle to reduce cross-contamination and to support the practice of standard precautions. A selection of fluoride trays is available for the clinician's use. There are 2 tray types that can be utilized, 1 for the maxillary arch and 1 for the mandibular. These trays also come in a variety of sizes: small, medium, and large. With gloved hands and the patient in an upright position, select the appropriate fluoride tray that will cover the patient's entire exposed enamel. The complete dentition must be covered, including the anterior and posterior teeth. Dispense a narrow ribbon of fluoride gel into the selected trays, no more than 1/3 of the tray height. Make sure to have the fluoride gel spread evenly throughout the tray. This may be done by pressing the sides of the tray together. The fluoride gel can also be spread by tapping it on a hard, clean surface. Another method to spread the fluoride gel is to use a cotton tip applicator. For easier access, it is recommended that the clinician place the filled trays on the bracket table before starting the fluoride procedure. Remove the patient's cup to ensure that the patient will not rinse after the trays have been removed from their mouth. Standing in the 8 o'clock position, the clinician will place the mandibular tray first. Holding the air and water syringe with your dominant hand, retract the patient's cheeks with the index and middle fingers of the non-dominant hand. Dry the patient's teeth thoroughly and remind the patient to stay open to keep the teeth dry. Make sure to dry the facial, occlusal, and lingual surfaces. Without removing the fingers, insert the mandibular tray over the teeth. Lift the patient's lower lip around the tray. The patient's head should be tilted forward at this time to avoid ingestion of excess fluoride. And a saliva ejector should be placed under the tongue. Standing in the 9 o'clock position, the clinician will insert the maxillary tray. As mentioned previously, the clinician retracts the cheeks and dries the teeth thoroughly before placement. Make sure to dry the facial, occlusal, and palatal surfaces. Without removing the fingers, insert the maxillary tray. Lift the lip over the edge of the tray. Once the trays have been inserted, ask the patient to close down and gently chew 2 to 3 times to ensure complete fluoride coverage. This procedure will need to be timed for 4 minutes using either a clock, a timer, or a wristwatch. The patient must never be left unattended during the procedure. After the timed 4 minutes, remove the saliva ejector and both trays. Because the patient has been instructed not to swallow or rinse, ask them to expectorate in the bowl. Utilizing a mouth mirror, inspect the oral tissues for any reactions that may have occurred. Ask the patient whether they are experiencing any burning, tingling, or irritation. Give the patient the postoperative instructions. The postoperative instructions are that the patient should avoid eating, drinking, or rinsing for 30 minutes after the fluoride application. This video will demonstrate the application of fluoride varnish. There are a variety of techniques to choose from. There is a single unit dose packet which is available in a pre-measured well, and a varnish tube that is dispensed on a pad. For the purpose of this video, the single dose application will be demonstrated. Preparation of the patient for varnish application. Review the patient's medical history for any contraindications, such as food and dye allergies. Give a detailed explanation of the rationale and procedure. Instruct the patient not to swallow. Position the patient in supine position. Dispense the varnish from the packet using an applicator brush. The applicator brush should be dipped into the varnish and mixed well to get a homogeneous mixture. Varnish sets up in the presence of saliva, but it is recommended to remove excess saliva by spraying air quickly on the teeth. Systematically paint a thin layer on all tooth surfaces. Starting with the mandibular teeth, apply the varnish on the facial, occlusal, then lingual surfaces, and repeat on the maxillary teeth. Make sure to provide full coverage to all areas of the teeth, including areas of recession. The application time is approximately 1 to 3 minutes for both arches. Instruct the patient that the teeth may have a yellow or clear temporary film on the tooth surface, depending on the manufacturer's product used. The varnish should be left undisturbed in order to provide the greatest therapeutic results to the treated areas. To obtain the maximum benefit from the varnish application, the patient needs to follow the postoperative patient care instructions. 1. Avoid hard, crunchy foods and hot drinks for 4 to 6 hours or until the next day. 2. Avoid brushing and flossing for 4 to 6 hours or until the next day. 3. It is advisable to drink through a straw for the next few hours. And 4. Remove the excess traces of fluoride the next day with a toothbrush and dental floss. Documentation of this service is essential. When recording the data, enter the summary on the services rendered page, and it is recommended to write it in a sequential order. Documentation of fluoride varnish. 1. 5% sodium fluoride varnish and flavor given. 2. Were there any reactions present? If yes, what were they? 3. Was the patient satisfied or not with the method or flavor?
Everyday lives. They serve both functionally to bite and chew, and aesthetically when showing off that nice shiny smile. Also, if you don't take care of your teeth, cavities and unhealthy gums will make your mouth very sore. So let's take a look at what you can do to keep your teeth healthy with these proper brushing techniques. The first technique is the horizontal technique. It is done by moving the brush back and forth on the teeth in a scrubbing motion. It is the method that most people use to brush their teeth. However, it is not recommended because it is very abrasive to the gums, which can lead to gingival recession. This next one is the phones method. It is done by moving the brush in a circular motion along clenched teeth. This is the technique that is taught to a young child and to those with very limited dexterity. Next up is the modified Stillman. In general, this is the most appropriate technique suitable for everyone and is highly recommended. This is accomplished by directing the bristles towards the gums at a 45-degree angle and placing the bristles partly on the teeth and partly on top of the gums. Next, vibrate the bristles with slight pressure to stimulate the gums. Then sweep towards the edge of the teeth. Repeat for the inside surface of the tooth. For the chewing surfaces, gently use a back and forth motion. Similar to the Stillman method is the Bass method. This is used for people with continuous receding gums. This method is identical to the Stillman method except for one modified step. When directing the bristles towards the gums at 45 degrees, instead of placing the bristles on top, you want to gently insert the bristles of the brush underneath the gums. The rest of the steps are the same. This final method is the Charters technique. This is not as commonly used and is for people with orthodontic and fixed prosthetic appliances. This method is also similar to the Stillman and Bass technique. However, the bristles are not directed towards the gums, but are instead directed 45 degrees towards the edge of the teeth. Our teeth play a very important role in our day-to-day living, and keeping them clean should be a daily priority. So remember to use these techniques to help aid in ensuring your teeth are healthy and your smile is shining.
The teeth. While brushing is important, the bristles of your brush simply don't remove plaque and bacteria from between the teeth. That's why we recommend that you floss every day. Don't worry about the type of floss. They all work pretty much the same. Wind 18 inches of floss around the middle fingers of each hand, leaving about 5 inches between your hands. Pinch the floss between your thumbs and index fingers, and leave about 1 inch in between to work with. Gently guide the floss down between the teeth using a side-to-side motion. If your teeth are too tight to floss, or if it catches or tears, let us know about it. These are problems that need to be fixed. Pull the floss tightly in a C shape around the side of the tooth and slide it under the gum line. Clean the surface of the tooth by moving the floss up and down several times to remove all the food and bacteria. Then pull the floss around the next tooth and repeat the process. Wind the floss to a fresh section and gradually work your way around your mouth, cleaning both sides of every tooth. If you have problems reaching some areas, you may want to use a floss fork. If your gums are infected, they'll bleed when you floss, and that's to be expected if you are just beginning to floss. After a week or so of regular flossing, the bleeding should go away, and you'll be well on your way to healthier teeth.
Your modified pen grasp is sort of the basics of your instrumentation, so it's important to get it right. So what you want to notice is the thumb and the index finger are opposing one another, and there's space in between those. It's not gripped together like that, but there's space between them. You can see the instrument so that you can roll the instrument when you need to adapt it. So the thumb is in this position. The index finger is pretty well bent, but not flexed a lot. The tall finger is slightly bent, a little less than the index, and the side of the instrument touches against this finger. And then your fulcrum finger is relatively straight, and that's your support. The baby finger doesn't matter at all.
This is a couple different ways you can hold your Profi cup as you work. So there's lots of different techniques. I am prone to dropping it, so I sometimes will just even keep it on my tray, but a lot of people will hold it like this in between their fingers, and then they'll even put like a piece of 2x2 in between there. So you can dab your cup in there and then dab on the gauze if you need it. Another way you can hold it is on this top side. You kind of make like a little hook with your ring finger. You can hold it in there. So you're holding your mirror through traction and you grab it like that. Another way you can do it is you can have one of these that you could purchase. A lot of the New Pro, if you order New Pro, it comes with them in the box. You can put it in between your middle and your ring finger. And that's super helpful to hold. Over time though, they tend to, over autoclaving them, they loosen up so the rings don't hold as well. The cups don't hold as well. You can buy the rings that have them built in. It's not as cost effective, but it's really helpful to be able to just have it stuck on your finger and it's stuck in there so there's no chance of it falling out. Okay, so buckle the first quadrant. The saliva ejector, any suction, any saliva, polishing paste in your cup. Retract. You're going to have the chin up, head straight ahead, sitting in 8 o'clock position, fulcruming on the maxillary teeth, anterior area. And you're going to retract with the back of the hand piece in the cheek area, and then start polishing from the distal to the mesial. And then again, if there's stain on the incisal half, do another Sweep with polisher. Again, you're flaring the cup only on the gingival third. Pat, pull, pat, pull. Up to including both premolars. Okay, so lingual of the first quadrant, saliva ejector, prophy paste in your cup. Turn your saliva ejector off. You're going to, with your non-dominant hand, go across the lower anteriors, and so that you can build your fulcrum up with your dominant hand and better access the lingual. The first, you see, you'll sit at 8 o'clock, head is towards you, chin up, and begin your technique from the most posterior. And again, working your way anterior. All the way to the first premolar. Okay, so on your saliva ejector, buckle of the second quadrant we're doing here, prophy paste. You're going to fulcrum on with your index. You're going to put your index finger on the occlusals of the third quadrant posteriors, and have the client close. Well, get your fulcrum on the index finger, so it's called a built-up fulcrum. Retract with the back of the hand piece. Ask the client to close slightly and begin your polishing technique from the posterior, working anteriorly. And work anteriorly until you see that the lip is going to start to fall over the handpiece. At that point, you want to stop, and you would continue with the area that you weren't able to get from there because the lip starts to fall down. You would do that area when you come across from the anterior area at the 11 o'clock position. So lingual of the second quadrant, chin down, head is turned away, 8 o'clock position. Suction, get your polishing paste. In your index finger of your non-dominant hand goes across the lower anteriors, and your polisher built-up fulcrum is used, and from there you're going to start at most distal and work all the way to the premolars. And then stop at the first premolar. Okay, we're polishing the fourth quadrant buckle. Run the saliva ejector first around the area that you're going to be polishing. Remove the saliva ejector, and you can place it back in the holder, or keep it in your hand if you like. Put some polishing paste on your polishing cup. What you're going to do is have the client's chin down, of course, and head straight ahead, and you're sitting at about 8:30 position. And you're going to come in and fulcrum on the anterior area with your polishing hand, and then starting at the very distal surface of the last molar, you're going to pat and pull. The stroke is called a pat-pull stroke, and flare the cup into the sulcus as you pivot and rotate into the mesial third, mesial half. And then you're going to go over the occlusal half of the tooth if there is stain there. If no stain, just again, you don't need to polish there. And then moving on to the next tooth. Pat, pull, the cup flares on the bottom half. The whole cup isn't on the tooth at the same time. And you don't have to use your index finger to retract, but I am for the mannequin in this purpose, just so that I could video better. Pat, pull, pat, pull, pat, pull. And moving across up to and including the premolar area. I'm only demonstrating the gingival third. However, if you need to come up to the incisal third as well, you would do that into another. Okay. Lingual of the fourth quadrant for the polishing. Run your saliva ejector across again. Polishing paste on. Turn your saliva ejector off. Then you can basically fulcrum on the anterior area with your polishing handpiece. Retract the tongue, the back of the, retract the tongue with the back of the handpiece, and start your polishing on the gingival third. Again, working from distal to mesial. Again, top half, if there's stain as well, go back over the occlusal third, and work your way across the teeth. Same technique all the way. 8 o'clock position, head towards you. And direct vision. Okay, buckle of the third quadrant for polishing. Head, chin is down, head is slightly towards the operator, clinician. Use the saliva ejector in the area. Saliva ejector turned off. Polish in your cup. And you're going to retract and put your left hand index finger along the buccal side or gingival area of the third quadrant posteriors. Go in with the polishing handpiece, retract with the back of the handpiece, and then your strokes are the same. Pat, pull. Gingival half, pat, pull if needed, and work your way forward anteriorly. To the premolar area. And maybe up to the mesial or so of that premolar. If the mesial, the premolar you can't reach, you can come and just move your position this way to get that mesial side better. Okay, for the lingual of the third quadrant, once again, run your saliva ejector across the area. Turn your saliva ejector off. Fill your polishing cup. Fulcrum right directly on the incisal edge of the anteriors. And retract the tongue with the back of the handpiece. And again, technique is the same. And for those premolars, you may have to have the client actually turn a little bit more away from you to see, and you may have to slide your position forward a little bit, get your direct vision on those teeth. And okay, so now we're moving on to the anteriors. And on the facial of the anteriors, remember where you left off from the 8 o'clock position when you were in the premolar area. Saliva ejector, rinse, evacuate, polishing paste on your polishing cup, and then continue from where you left off from the buckle of the second quadrant and work your way then into the anteriors. Again, longer tooth, you'll need to do a couple of sections if there's stain. And as you get to the centrals, you'll start asking the client if they could straighten their head up. And by the way, we're at 11 o'clock for this position. And by the time we get to this first quadrant anteriors, you have the client turn their head away. And that would be it to the canine. Okay, the lingual of the max anteriors. This is the area you'll be at 11 o'clock and using indirect vision. So we'll start on the 2-3 and have the client's head towards you slightly so that you can start, and again looking indirect vision. And work towards your fulcrum. You're fulcruming right directly on the incisal edge of the max anteriors. And as you're working across the area, add some more paste as needed, and have the client's head, ask the client to turn a little bit away from you. To the 1-3. Buckle of the mand anteriors. You're sitting at 8 o'clock again, and you're going to put your index finger in the vestibule, and you're going to, again, when we came from the buckle of the 4th, we polished with the fulcrum directly on the tooth. Now you can go across those mand anteriors up to wherever you're able to, and then when you're not able to do it comfortably anymore, then you would be able to put your hand on top of your index finger of your left and just use a built-up fulcrum for the remainder of those mand anteriors, and finish off on the canine from this position. Oops, well, you can even do the distal as you swiveled it and going this way actually.
Okay, so for polishing, we are going to go through the whole technique. Our rheostat has to be on the correct setting. Also, this is my hand piece here. We have the motor and the cone, and we have our prophy angle. And we also have to get our prophy paste here. I like to just hold on to mine, but we do have a couple different things that you can use as a holder to make it a little bit easier for you. So I'm going to remove the lid off of my prophy paste, and until you get a really good grasp on hearing the kind of the rotations that are adequate for polishing, you kind of want to gauge over here on the tray is a little dial. So you want to be between 10 and 15 rotations. So that is about how fast you want to use for polishing, even a little lighter, I would say. Okay, so before you start polishing, you want to apply the prophy paste. So we're going to gather some in the cup and kind of just smear it over 3 or 4 teeth. Just like that. So we're going to start with a technique. We're going to go down the center and then do side and side. When you're pressing the cup against the tooth, you want to flare the cup toward the gum line, like this. So I'll show you one. And then you want to make sure that cup flares into the interproximal space. Just like that. It's going to be hard to have a fulcrum here. You can have an extraoral fulcrum on a hard surface like the cheekbone or the chin. If you can get a fulcrum on the tooth, that would be fine as well. Usually you use that for the lingual surfaces, like this. So you want to go down the center, and flaring the cup at the gum line, side, side, and just make your way all the way around. You do need to put some pressure, and if you're going to hear the cup stop a little bit, but you really want to make sure you're flaring the cup and you put enough pressure, otherwise you're going to be sliding around all over the tooth like this, and that's not going to help. So we're going to get every surface, facial, lingual, and then occlusal for the posterior teeth, and that is how you polish.
I actually hold the prophy paste in my hand like so, with some 2x2 gauze right here to wipe excess saliva. So my prophy paste is between those 2 fingers. I hold like this, and I can come in and grab. So I keep these 2 fingers tucked so they're not in the way. And I also take my thumb, pinch it like this, so I can use this finger as retraction. Go ahead and turn a little bit away from me, Candy, and close just a little bit. I have my patient close a little bit so I can get more extension on retracting their cheek and have them still be comfortable. What I'm going to do is I'm just going to make sure I come across the gingival margin and then clean the tooth. I'm going to show you the whole mouth. This is one option of the sequence. There are many out there. Reload. And fulcruming on her chin using an extraoral fulcrum. Turn towards me. Turn more towards me. Thank you. If my patient presents with stain on the anterior lingual teeth, I will use my mirror to take a look and make sure that I'm using the Prophy polish as a stain remover. A lot of patients hate this, and they hate to swallow it. So if my patient is filling up with water or saliva, I'll let them close on the saliva ejector. Candy here is doing just great. She doesn't have a lot of spit going on, so thanks, Candy. I always make sure I have a fulcrum as to not fly off the tooth or fling Prophy paste everywhere. When I first started as an assistant, I was messy Jessie. I had Prophy paste all over my clothes, all over the patient, all over the operatory, and all over everything. One tip, when it gets clogged like that, I just run it across my 2x2. Go ahead and open for me, Candy. One tip that I've heard is to start here on the lingual, as that's where most of the saliva gathers. When polishing. I feel like if you do a really good job with your scaling, you don't have to do a ton of marginal polishing as you remove that biofilm with your instruments. Don't forget the occlusals. They don't get any action with the instruments.
So instead of using a indexing tab, the little chewy one, if you have a patient that has a hard time chewing or like a kid, you can use this gel instead, which is pretty handy. So the first thing you're going to do is just put a little bit on a 2x2 before you put it on your tray, and it's pretty runny and it dyes. So you want to be super careful around your scrubs or around your patient's clothes, because if it gets in there, it's really hard to get off. And just paint it on, and usually towards the gingiva is the best. You can use a little bit of water, just rinse the excess off really gently. This two-tone is pretty cool. So the darker the color, the older the biofilm. So the bright pink is new, it's in the last 24 hours, and then anything dark pink to bluey purple, older. So it's a really great educational tool for your patients to show them where they're missing, and they can't use that excuse, I just ate lunch.